In this video, we'll review ACLS, or Advanced Cardiovascular Life Support, with a focus on the adult cardiac arrest algorithm. We will go step by step how to recognize cardiac arrest, how to separate shockable from non-shockable rhythms, when to defibrillate, when to give medications, and how to search for reversible causes. This video is for educational purposes and does not replace certified ACLS training, clinical judgment, or local hospital protocols. By the end of this video, you should understand definition of ACLS, how to recognize adult cardiac arrest, high-quality CPR, airway and ventilation, shockable versus non-shockable rhythms, algorithm, drug doses in adult cardiac arrest, reversible causes, H's and T's, ROSC, what happens after the pulse returns, complications, and team roles. Definition: ACLS is an organized approach to life-threatening cardiovascular emergencies, especially cardiac arrest and unstable arrhythmias. ACLS builds on BLS, high-quality CPR, early defibrillation, airway ventilation, rhythm diagnosis, medications, and team-based care. Recognition. When do we start the ACLS algorithm? We recognize cardiac arrest by three key findings: the patient is unresponsive, not breathing normally, and has no definite central pulse. Breathing may be absent, or the patient may have agonal breathing, which means irregular gasping breaths. The patient may also appear pale, grey, or cyanotic. The pulse check should take no more than 10 seconds. If there is no definite pulse, start CPR immediately, call for help, and attach the monitor or defibrillator. Then identify the rhythm. Shockable, like ventricular fibrillation or ventricular tachycardia, or non-shockable, like asystole or pulseless electrical activity. High-quality CPR is the foundation of ACLS. During cardiac arrest, chest compressions maintain coronary and cerebral perfusion. In simple terms, CPR is what provides blood flow to the myocardium and brain until we achieve return of spontaneous circulation, or ROSC. For adults, compression should be delivered at a rate of 100 to 120 per minute, with a depth of at least 5 centimeters. We should allow full chest recoil and avoid leaning on the chest, because incomplete recoil reduces venous return. Interruptions should be minimized. Every pause in compressions decreases coronary perfusion pressure, and this can reduce the chance of successful defibrillation and ROSC. The compressor should be changed every 2 minutes or earlier if fatigued. Airway and ventilation are also important, but they should not interrupt chest compressions. Initially, we open the airway, give oxygen, and ventilate with a bag mask device. CPR is performed with a ratio of 30 compressions to 2 breaths, also written as 30 to 2. This means we give 30 chest compressions, then pause briefly to give 2 ventilations. Once an advanced airway is in place, chest compressions continue without pauses, and ventilation is given once every 6 seconds, which is about 10 breaths per minute. We should avoid excessive ventilation. Hyperventilation can increase intrathoracic pressure, reduce venous return to the heart, and worsen cardiac output during CPR. If available, waveform capnography should be used. It helps confirm advanced airway placement, monitor CPR quality, and may give clues about ROSC. So the key message is: compress, allow full recoil, minimize pauses, ventilate carefully, and do not let airway management interrupt CPR. While you do high-quality CPR, attach a defibrillator as soon as possible. A defibrillator is a medical device that delivers an electrical shock to the heart. In ACLS cardiac arrest, we divide rhythms into 2 main groups: shockable and non-shockable rhythms. Shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. These rhythms are treated with defibrillation because the problem is a disorganized or life-threatening ventricular electrical activity. The goal of the shock is to reset the heart's electrical activity and allow an organized rhythm to return. Non-shockable rhythms are asystole and pulseless electrical activity, also called PEA. These rhythms are not treated with defibrillation. Instead, the priority is high-quality CPR, early epinephrine, and searching for reversible causes. So the first question after rhythm analysis is simple but critical: is the rhythm shockable? If yes, stay away from the patient and don't even touch the bed. Give shock and immediately resume CPR for 2 minutes. If you touch the patient while giving shock, you will shock yourself. The recommended joules is between 120 and 200. If no, we continue CPR, give epinephrine as soon as possible, and look for causes such as hypoxia, hypovolemia, acidosis, hypokalemia, tamponade, tension in pneumothorax, toxins, pulmonary thrombosis, or coronary thrombosis. This rhythm decision guides the whole ACLS cardiac arrest algorithm. This slide shows a simplified adult cardiac arrest algorithm. The first step is to recognize cardiac arrest. The patient is unresponsive and not breathing normally. Breathing may be absent, or the patient may have agonal breathing, which means abnormal gasping breaths. Once cardiac arrest is suspected, we call for help, start CPR with a ratio of 30 compressions to 2 breaths, and attach the defibrillator or monitor as soon as possible. The next step is rhythm analysis. In adult cardiac arrest, we divide rhythms into 2 main groups, shockable rhythms and non-shockable rhythms. Shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. These rhythms require defibrillation. After giving a shock, we immediately resume CPR for 2 minutes. We do not stop to check the pulse immediately after the shock. After 2 minutes, we reassess the rhythm. If the rhythm remains shockable after repeated shocks, we continue high-quality CPR. Give adrenaline 1 mg IV every 3 to 5 minutes, and consider amiodarone, usually 300 mg first, then 150 mg if needed. Non-shockable rhythms are pulseless electrical activity and asystole. These rhythms are not treated with defibrillation. Instead, we resume CPR immediately, give adrenaline 1 mg IV as soon as possible, and repeat it every 3 to 5 minutes. Then we reassess the rhythm. In both pathways, we must search for reversible causes. These are called the H's and T's: hypoxia, hypovolemia, acidosis, hypo or hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, pulmonary thrombosis, and coronary thermy. If return of spontaneous circulation, or ROS, is achieved, the focus changes to post-arrest care. We optimize oxygenation and ventilation, treat hypertension, obtain a 12-lead ECG, and identify and treat the underlying cause. Now let's talk about the pharmacology used during adult cardiac arrest. The most important point is that drugs are supportive. They do not replace high-quality CPR or early defibrillation. During cardiac arrest, the foundation is still chest compressions, oxygenation, rhythm recognition, and treatment of reversible causes. The main vasopressor used in cardiac arrest is adrenaline, also called epinephrine. The adult dose is 1 mg IV or IO, repeated every 3 to 5 minutes. The main pharmacological effect we want during CPR is alpha-1 vasoconstriction. This causes peripheral vasoconstriction and helps increase aortic diastolic pressure. As a result, coronary perfusion pressure and cerebral perfusion pressure may improve during chest compressions. In non-shockable rhythms, meaning PEA and asystole, adrenaline should be given as soon as possible because these rhythms are not treated with defibrillation. In shockable rhythms, meaning ventricular fibrillation and pulseless ventricular tachycardia, the first priority is defibrillation. Adrenaline is given during CPR after repeated shocks and then repeated every 3 to 5 minutes. For refractory VF or pulseless VT, we consider antiarrhythmic therapy. The first option is often amiodarone. Amiodarone is mainly a class 3 antiarrhythmic drug. It prolongs repolarization and helps stabilize ventricular electrical activity. The adult cardiac arrest dose is 300 mg IV or IO bolus. If VF or pulseless VT continues, a second dose of 150 mg may be given. Lidocaine is an alternative to amiodarone. It is a class 1B antiarrhythmic drug. It acts on sodium channels and can suppress ventricular arrhythmias. The first dose is 1 to 1.5 mg per kilogram IV or IO, followed by 0.5 to 0.75 mg per kilogram if needed. Some drugs are only used in special situations. Magnesium may be considered if Torsades de Pointes is suspected. Calcium or sodium bicarbonate should not be given routinely to every cardiac arrest patient, but they may be useful in selected causes, such as severe hyperkalemia or certain toxicological arrest. Thrombolysis may be considered if massive pulmonary embolism is strongly suspected, so the pharmacology of cardiac arrest is not about giving many drugs. It is about giving the right drug at the right time for the right rhythm while maintaining high-quality CPR and treating the underlying cause. Reversible causes, H and T's. Now let's talk about reversible causes of cardiac arrest. In ACLS, these are commonly remembered as the 5Hs and 5Ts. This is important because CPR, defibrillation, and adrenaline may not be enough if the underlying cause is not treated. The 5Hs are hypovolemia, hypoxia, hyperkalemia, or hypokalemia, hydrogen ions meaning severe acidosis and hypothermia. The 5Ts are tension pneumothorax, cardiac tamponade, toxins, pulmonary thrombosis, and coronary thrombosis. Let's go through them one by one. Hypovolemia. Hypovolemia means reduced circulating blood volume. This can happen from major bleeding, trauma, dehydration, sepsis, or fluid loss. During cardiac arrest, we can consider POCUS, which means point-of-care ultrasound, to look for signs of volume depletion or bleeding. Management includes IV fluid resuscitation and, if bleeding is present, hemostatic control. That means we must stop the bleeding and replace lost volume. Hypoxia. Hypoxia means inadequate oxygen delivery. This can be caused by airway obstruction, respiratory failure, aspiration, drowning, pneumonia, or problems with ventilation. Supporting investigations include an ABG or arterial blood gas, and we can also consider POCUS. Management is to give supplemental 100% oxygen, secure the airway when needed, and provide effective ventilation. This may include tracheal intubation and positive pressure ventilation. The key is to correct oxygenation and ventilation as quickly as possible. Hyperkalemia or hypokalemia. One important reversible cause of cardiac arrest is potassium abnormality. This includes both hyperkalemia and hypokalemia. Hyperkalemia means a high potassium level, usually above 5.5 to 5.6 millimoles per liter. It is especially dangerous because it can directly affect cardiac conduction and myocardial excitability. Clinically, hyperkalemia may cause muscle weakness, paresthesia, confusion, bradycardia, and life-threatening arrhythmias. On ECG, we may see peak T waves early. As hyperkalemia becomes more severe, we can see PR prolongation, QRS widening, conduction delay, a sine wave pattern, ventricular arrhythmias, PEA, or asystole. Hyperkalemia should be suspected in patients with renal failure, missed dialysis, crash injury, severe acidosis, diabetic ketoacidosis, or medications such as ACE inhibitors, ARBs, potassium-sparing diuretics, or potassium supplements. The treatment has 3 goals. First, we stabilize the myocardium with intravenous calcium. This does not lower the potassium level, but it protects the heart from the electrical effects of hyperkalemia. Calcium can be given as calcium gluconate or calcium chloride, depending on local protocol and IV access. Second, we shift potassium into the cells. This can be done with insulin and glucose and nebulized salbutamol. Sodium bicarbonate may be considered when severe metabolic acidosis is present or in hyperkalemic cardiac arrest according to local guidance. Third, we remove potassium from the body. This may include fluids and loop diuretics if the patient can produce urea, potassium binders in selected cases, and hemodialysis, especially in severe or refractory hyperkalemia. Hypokalemia means a low potassium level, usually below 3.5 millimoles per liter. It can also cause serious arrhythmias, especially in patients with heart disease, digoxin use, poor intake, vomiting, diarrhea, diuretics, or magnesium deficiency. Symptoms of hypokalemia include muscle weakness, cramps, fatigue, paresthesia, and reduced gastrointestinal motility. ECG changes may include ST depression, T-wave flattening, prominent U waves, QT prolongation, and ventricular arrhythmias. Treatment depends on severity. If the patient is stable and the hypokalemia is mild, oral potassium replacement is usually preferred. If hypokalemia is severe, symptomatic, associated with ECG changes, or occurs during cardiac arrest, IV potassium chloride may be required. We should also check and correct magnesium, because hypomagnesemia can make hypokalemia difficult to correct. The key message is that potassium abnormalities are treatable causes of cardiac arrest. In suspected hyperkalemia or hypokalemia, we should not only continue CPR, we should actively correct the potassium disturbance. Hydrogen ions during cardiac arrest, acidosis develops because of poor tissue perfusion and anaerobic metabolism. Supporting tests may include a VBG or ABG. A VBG is a venous blood gas, and an ABG is an arterial blood gas. Management focuses on correcting the cause of the acidosis. We should optimize ventilation, increase minute ventilation if there is hypercapnia, and avoid excessive hyperventilation, because hypercapnia can also be harmful. Hemodynamic support is important, meaning good CPR, vasopressor support when indicated, and treatment of the underlying cause. Sodium bicarbonate is not given routinely in cardiac arrest. It may be considered only in selected situations, such as severe hyperkalemia or specific toxicological causes, but routine use of 8.4% sodium bicarbonate during cardiac arrest is not recommended. Hypothermia. Hypothermia can cause severe bradyarrhythmias, ventricular fibrillation, and cardiac arrest. We assess the temperature. Severe hypothermia is below 30 degrees Celsius, moderate hypothermia is 30 to 34 degrees Celsius, and mild hypothermia is above 34 degrees Celsius. Management includes core rewarming, external warming devices, and infusion of warm IV fluids. In severe cases, especially if the patient is in cardiac arrest, we may need to consider cardiopulmonary bypass or extracorporeal support if available. Tension pneumothorax. Tension pneumothorax means air is trapped under pressure in the pleural space, compressing the lung and impairing venous return to the heart. It can cause obstructive shock and cardiac arrest. POCUS may support the diagnosis. Findings can include absence of lung sliding on the affected side when the patient is ventilated. This is sometimes called the barcode sign or loss of the seashore sign. There may also be loss of B-lines. Management is urgent. We perform emergency needle thoracostomy, followed by tube thoracostomy. Cardiac tamponade. Cardiac tamponade means fluid or blood accumulates around the heart, preventing proper ventricular filling. It can occur after trauma, procedures, malignancy, pericarditis, or aortic dissection. POCUS can show free fluid around the heart. The clinical sign is hypertension, distended jugular vein, muffled heart sound. This is what we call a Beck's triad. Management is emergency pericardiocentesis or surgical drainage depending on the situation and local resources. Toxins. Toxins include overdose, poisoning, and drug-related cardiac arrest. A VBG or ABG may show metabolic acidosis, especially an anion gap acidosis. Co-oximetry can help identify carboxyhemoglobinemia, which is important in carbon monoxide poisoning. Management depends on the toxin. In opioid toxicity, naloxone can be administered if it does not interrupt CPR. In local anesthetic systemic toxicity, we give lipid emulsion therapy and modify ACLS according to local toxicology guidance. In sodium channel blocker overdose, such as tricyclic antidepressant overdose, 8.4% sodium bicarbonate may be used. In carbon monoxide toxicity, management includes ventilation with 100% oxygen. Pulmonary thrombosis. Pulmonary thrombosis usually means massive pulmonary embolism. It can cause sudden collapse, severe hypoxia, obstructive shock, and often PEA arrest. POCUS may show evidence of DVT in the proximal lower limbs and right ventricular dilation. Management may include thrombolysis or embolectomy, anticoagulation, and hemodynamic support. In selected patients, ECMO may be considered. Coronary thrombosis. Coronary thrombosis means acute coronary artery occlusion, usually myocardial infarction. We should consider coronary thrombosis, especially if rhythm analysis shows ventricular fibrillation or ventricular tachycardia. Management includes emergency PCI, which means percutaneous coronary intervention. If PCI is not available, thrombolytic therapy may be considered, depending on the clinical context and local protocol. ROSC. What happens after the pulse returns? ROSC means return of spontaneous circulation. In simple terms, the patient has a pulse again. After ROSC, the focus changes. We are no longer doing the cardiac arrest algorithm. Now the priority is post-arrest care because the patient is still critically ill and may arrest again. First, we confirm circulation. We check for a central pulse, blood pressure, signs of life, and an organized rhythm on the monitor. If available, a sudden rise in end-tidal CO2 can also support ROSC. Then we reassess the patient using the ABCDE approach. For airway and breathing, we optimize oxygenation and ventilation. Initially, oxygen may be high, but once oxygen saturation can be measured reliably, we titrate oxygen to avoid both hypoxia and unnecessary hyperoxia. We also aim for normal ventilation, because both hypercapnia and hypocapnia can be harmful after cardiac arrest. For circulation, we treat hypertension. This may require IV fluids, vasopressors such as noradrenaline, and sometimes inotropes depending on the cause. The goal is to maintain adequate organ perfusion, especially cerebral and coronary perfusion. A 12-lead ECG should be obtained as soon as possible after ROSE. This helps identify ST elevation, myocardial infarction, arrhythmias, or other cardiac causes of arrest. If acute coronary occlusion is suspected, the patient may need urgent coronary angiography and PCI. We also continue to search for the underlying cause. This may include blood gases, electrolytes, glucose, lactate, echocardiography, chest imaging, CT, or other investigations depending on the clinical picture. Neurological care is also important. We assess consciousness, treat seizures if they occur, avoid fever, and consider temperature control in patients who remain comatose after ROSC. So the key message is ROSC is not the end of resuscitation. It is the beginning of post-cardiac arrest care. We must stabilize oxygenation, ventilation, circulation, brain protection, and treat the underlying cause. Complications, cardiac arrest, and resuscitation can both lead to complications. First, the cardiac arrest itself can cause severe complications because organs are exposed to reduced blood flow and reduced oxygen delivery. The brain is especially vulnerable, so one of the most important complications is hypoxic brain injury. Patients may also develop myocardial dysfunction, shock, multi-organ failure, recurrent cardiac arrest, or death. Second, CPR can cause mechanical injuries. Chest compressions can lead to rib fractures or sternal fractures. In some cases, patients may develop pneumothorax, hemothorax, pulmonary contusion, or internal injury. These complications can sound dramatic, but they should not stop us from performing high-quality CPR because untreated cardiac arrest is fatal. Airway and ventilation can also cause complications. Bag mask ventilation may cause gastric insufflation, which increases the risk of regurgitation and aspiration. Intubation can be difficult during resuscitation and may cause airway trauma, esophageal intubation, or prolonged pauses in compressions if not performed carefully. That is why airway management should not interrupt CPR. Third, after ROSC, the patient can develop post-cardiac arrest complications. These include hypertension, recurrent arrhythmias, seizures, fever, respiratory failure, and neurological injury. The patient may also develop reperfusion injury, where blood flow returns but inflammation and cellular injury continue. This is why ROSC is not the end of treatment. After the pulse returns, the patient still needs structured post-arrest care, controlled oxygenation and ventilation, blood pressure support, ECG assessment, treatment of the underlying cause, seizure management, temperature control, and intensive monitoring. The key message is that complications are common, but the most dangerous complication is delayed or poor quality resuscitation. Team roles. During cardiac arrest, good team organization is essential. ACLS is not performed by one person. It requires a coordinated team where everyone knows their role. Clear roles reduce confusion, prevent duplicated tasks, and help avoid delays in CPR, defibrillation, medication administration, and rhythm reassessment. The first role is the team leader. The team leader should stand back when possible, maintain the overall view, assign roles, and guide the algorithm. The leader decides when to analyze the rhythm, when to shock, when to give medications, and when to search for reversible causes. The compressor is responsible for high-quality chest compressions. This includes the correct rate, correct depth, full recoil, and minimal interruptions. The compressor should be changed every 2 minutes because fatigue quickly reduces CPR quality. The airway person manages oxygenation and ventilation. This includes opening the airway, using bag mask ventilation, avoiding hyperventilation, and assisting with an advanced airway when appropriate. If an advanced airway is placed, waveform capnography should be used when available. Another team member should manage a defibrillator or monitor. This person attaches the pads, recognizes the rhythm, charges the defibrillator, announces when everyone must stand clear, and delivers the shock safely when indicated. A separate person should manage IV or IO access and medications. This includes preparing and giving adrenaline, amiodarone, lidocaine, or other drugs according to the rhythm and clinical situation. Drug name, dose, and route should be said out loud. The recorder or timekeeper is also very important. This person documents the arrest, the rhythm, shocks, medications, airway interventions, and time intervals. They can also remind the team when the next 2-minute rhythm check or medication dose is due. The most important communication principle is closed-loop communication. This means the leader gives a clear instruction, the team member repeats it back, performs the task, and then confirms when it is done. For example, the leader says, "Give adrenaline 1 mg IV now." The medication person replies, "Adrenaline 1 mg IV." After giving it, they confirm, "Adrenaline 1 mg IV given." This prevents misunderstandings, especially during a high-stress resuscitation. The key message is that good ACLS depends on both medical knowledge and team performance. A well-organized team can deliver CPR, defibrillation, drugs, airway management, and post-arrest care more safely and efficiently. Thank you for watching. This video is intended for educational review only. In clinical practice, always follow your local protocols, hospital guidelines, and certified ACLS.